All right, so with that, we'll move on to our last speaker of the day. Ted Panov, we all know, is one of our faculty in the Functional and Epilepsy division here at Mount Sinai. He completed his MD at Jefferson and his residency here at Mount Sinai before heading off to California for a fellowship in functional neurosurgery and epilepsy with Eddie Chang. He is widely published. He has an extremely academic approach to his work, which I've been fortunate enough to witness in our epilepsy conferences, and a very thoughtful approach to taking care of his patients. And he'll be speaking to us today about functional neurosurgery and epilepsy.
Thank you, Peter, for that kind introduction. And just let me know if I'm able to share correctly. And that looks like the final slide, huh?
You do see it.
Okay. All right, how about the first slide? Are we good?
Got it.
All right. Well, guys, it's always such a pleasure to be able to discuss some of these research efforts with the greater Mount Sinai neurosurgical community. The title today is Impact of Meditation on Limbic Circuit Reactivity. And I must say, I believe my passion for this topic most certainly outweighs my knowledge. And our entire team is looking for feedback and possible collaboration as we get some of these research projects going. Quick outline of what we will cover today includes historical background into meditation and its eventual and hopeful collision with intracranial recordings. The current evaluations of chronic meditation, so what is out there in the literature right now. The potential meditation paradigms that we can introduce in our comprehensive epilepsy center, and future directions for us as a field as we start embracing some of these traditions. So if we go back, the first mentions of meditations are pictorial. They're not written, and they go back between 5,000 and 7,000 before current era. And this would be wall art from the Indian subcontinent. This would be positions of individuals in clearly meditative poses with eyes closed or half open, testifying to the fact that this has been around for, I'm saying 6,000, but at least 7,000, potentially 8,000 years. The first written documentations of this would be in the Indian subcontinent writings, about 3,500 before current era, and those would be the Vedas. And from that point on, we move to the spread from just Hinduism to other religions, including Taoism and Buddhism, about 2,500 years ago, moving over into the Middle East with some paradigms in the Old Testament, now interpreted as meditative practices. The Roman Empire around the 1st century before current era, and sliding into, until its demise, around the 4th and 5th century of the current era. One of the fascinating aspects of this is a lot of the early Christian thinkers attempted meditation, and one of the famed ones, St. Augustine, actually gave up on meditation when he allegedly could not achieve ecstasy. Pretty high bar, and I'm sorry that he gave up on it. The Middle Ages stretched us into Kabbalistic meditation and the Judaism faith, and some of the mysticism around the Sufi branches of Islam. And only really the last 150 to 200 years are we talking about it really entering Western mainstream. To compare with what we're discussing here and what we'd like to fuse it to modern neurosurgery, most likely it's a spot right over here, not quite to scale, but just to give you a perspective of the tradition of what we would normally call alternative medicine, where in this case, most likely is actually traditional medicine. Each religious spiritual discipline that we were able to look at includes meditation-like practices. So a quick list, in Hinduism, we talk about Isha Yoga and Himalayan Yoga. In Jainism, meditation is critical to that faith. Another interesting component of Jainism is you have to wear masks at all times. So we were thinking this would be a really good faith to adopt currently. They cannot kill any other living being, and they would always wear a mask to prevent breathing in insects. Sometimes there's a person walking ahead of them, swiping the ground to assure that they do not step on any insects. Judaism, as we said, the Old Testament prophets would go out into the desert and meditate. In the Kabbalah, the divine name of God can be considered a mantra that is now more utilized in Western and transcendental meditation. Buddhism, Vipassana yoga is a good off-branching from the previous Hinduism faiths. And even stretching into Christianity, something like Catholic prayer beads. Again, continuous recitation can be considered a mantra-esque attempt at meditation. Then you have Islam, as we discussed before, centralization and concentration, this term of tamarkaz, and the Mevlevi order, which we probably all know better as the whirling dervishes. Again, entering into, and I apologize, this video is not working, but entering into a state of a trance as you continuously spin in a certain rotation. This is a bit of a jest, but Wicca, Thelema, Neopaganism, occultism, I will put neurosurgery here because I do truly believe that each one of us has their own early onset of meditation, whatever it may be. I remember Dr. Bettison stressing with us, when you are washing your hands, those 5-10 minutes, really set everything else aside and, focus on the case. Forget about the distractions. Think of the ways that you can potentially harm the patient and work your way through avoiding that. This could be swimming, this could be exercise, but a lot of us already do meditate. We just don't consider labeling it so. Excuse me. So what are the perceived benefits of meditation? Well, this gentleman right here, Matthew Ricard, is known as the happiest person in the world. Hard to confirm something like this, but a lot of good research has been done, mostly in Wisconsin-Madison under the guidance of Dr. Davidson. Stress relief, increased ability to focus, performance, and specifically stoic performance during difficult and dangerous tasks under significant pressures. It sounds like neurosurgery to me. Intense serenity, bliss, enhanced physical well-being, heightened self-awareness, the perception of time dilates, almost a mystic religious experience. And this is the first trick of the lecture. This right here actually is not what is reported as a perceived benefit of meditation, but is a description of a type of epilepsy. And I want to start making this connection and foreshadowing this early on. This is actually Dostoevsky describing ecstatic epilepsy, which is thought to reside in the anterior insula. What should have been in that slide is increased happiness. And in the lay person's term, this is labeled as loving kindness, improved emotional regulation, amelioration of anxiety and depression, and the boost of positive mood. I would like to pitch this book to everyone who has time, maybe for your next flight when we're able to travel. A really good description of the career and the life path of this gentleman here, who in his early 20s forsaken his PhD academic career in France and went to Tibet and became a monk. So what do we have peer review research-wise regarding meditation? Well, there is research showing that there is going to be excessive activity in the left prefrontal cortex compared to the right. Now, obviously, due to patient confidentiality, we don't know that that research was specifically regarding Matthew Ricard, but he was part of that study, and the study is published just without his name. Abnormally large capacity for happiness and reduced propensity towards negativity, and this is all used quantitative and qualitative scales. Long-term practitioners are categorized as people who have done more than 50,000 rounds of meditation. So this is a lifetime commitment. But at the same time, you can make a difference with short-term investment, and that would be 20 minutes a day for 3 weeks, having a retreat, 3 days, 7 days, 10 days of a silence retreat where you learn mantra meditation. So this is one of Dr. Davidson's papers, Impact of Short and Long-Term Mindfulness on specifically the reactivity of our limbic circuit on the amygdala. And what they found is that people who have meditated for a long time are able to decrease reactivity to negative images. People who have moderately meditated, let's say one of these 8-week courses, are able to decrease the reactivity to positive images, which surprisingly is also very important. And it looks like there is reduced amygdala reactivity and increased connectivity to the ventromedial prefrontal cortex. And this may decrease emotional liability of a person. Now, that study was done with fMRI bold signal. This next one here is increased gamma brainwave amplitude compared to control in 3 different meditation traditions. So what they found is increased gamma activity. We usually call this high gamma, around 60 to 110. And all of these, Vipassana, Himalayan yoga, Isha Shunya or Isha yoga, allow for this kind of movement of your high frequency brain activity. And a quick review between focused attention meditation and open monitoring meditation. So the best way to describe this, Himalayan yoga would be akin to Catholicism reciting 10 Marys. So it's focused attention on mantra-based, which means you will be reciting a phrase, and at some point that should fade away from your attention, but it's still a focus-based meditation on something that is external. Vipassana is a little bit more towards the open monitoring. This would be focusing on somatosensory awareness. Let's say we had a discussion yesterday focusing on the tip of your nose or on the bridge of your nose and spending hours doing that. Whereas Isha Yoga stands a little bit more in the open monitoring phase, and that is really trying to think of nothing. And as a personal experience, there was nothing worse than a 5-year-old when my dad told me to go stand in the corner and not think about the polar bear. And the moment I was able to achieve that, I could finish my punishment and leave the corner. Incredibly difficult to achieve, and most certainly does focus on internal stimuli, interoception, and also allows potentially thoughts to just flow through your brain without getting stuck on any one of them, eventually achieving this open monitoring state. So research on chronic meditators here showed that the EEG gamma power correlated with the reported depth of the meditation session. And you guys can see in this graph here, as we head towards frequency above 60, you can see significant separation between the purple line of controls and the other 3 lines of meditation. The types of meditation we'll have to leave for a later talk. This is clearly a rabbit hole from which there's no escape because the definitions, unfortunately, are still so fluid. You have Buddhist meditation, which is Zen and mindfulness. You have transcendental meditation, which can be completely a-religious and hence more potentially approachable to the majority of our patients and faculty. This would be mantra-based. You have yoga meditations, which would be postures, positions, breathing, and still mantra. And you have sort of the last 200 years building on the last 20, 30 years of technological advances where you have paced breathing and device-augmented meditation. So one of the devices we'll discuss today is the Muse, and the other one is the NuCalm. So device-based meditation, again, is not FDA approved really for any reason, but it is FDA cleared as a low-risk device. And there will be, again, some asterisks to that, and I do want to have a word of caution before we proceed. So NuCalm utilizes acupuncture meridians for biofeedback. They will introduce things like GABA tablets during these sessions. They will actually put a GABA gel on your neck to try to access the vagal nerve and use tea extract. They will use neuroacoustic software frequencies to allegedly slow the brain function. So again, all of those things from the basis of us as scientists are not quite to the level of power of peer review research, but most certainly this is allowing the population of the United States and other first world countries to really embrace meditation and to give it a try and to get people interested in it. So this device here, the Muse, is a little bit less labor intensive. This utilizes heart rate and EEG from sensors across the frontal lobe here on the forehead, as well as a couple of sensors in the temporal lobe just behind your ear to monitor heart rate and EEG for biofeedback. There is no medicinal augmentation, although that's up to the patient, of course. And acoustic software allows you biofeedback, whereas you're guided to the alleged depths of your meditation during the session itself. Now, I do want to caution everyone at this talk, specifically because epileptiform potentials are similar to this chronic meditation state of high gamma. And you know, there's some questions about the loving kindness state of meditation that is achieved approaching some interictal discharges that we see in our patients when we monitor them in and out of the epilepsy monitoring unit. Is there any connection between meditation and this ecstatic epilepsy that is reported in the anterior insula? This is an incredibly charged topic in the literature. Most seem to agree to say that meditation is protective and that the connection between meditation and epilepsy is more of a final common pathway. Meditation is really not something that will potentially promote or start epilepsy in patients. But a few in the literature, as you see here, do disagree. So let's quickly cover the ecstatic seizures that we spoke about initially as foreshadowing in this talk. So there's not a lot of cases reported in the literature, and we'll discuss the reason for that why as well. They are difficult to describe, but overwhelmingly, they're stated to be a positive experience. The most vivid descriptions, as we mentioned before, will be in the writings of Dostoevsky, and it's argued whether he had temporal lobe epilepsy, which stayed away from being generalized long enough to actually trigger some of these limbic circuits and for him to experience this ecstatic epilepsy. And you guys have seen the descriptions of this before, right? Intense serenity, bliss, enhanced well-being, heightened self-awareness, change in the perception of time, all together with, unfortunately, an ominous experience that they would describe, because usually following this is a generalized seizure. So while this overwhelmingly positive experience goes on, the patient is aware that this potentially can go to a generalized convulsion and embarrass them or hurt them. The interesting part here is it's documented to be potentially triggered by focus on specific memories or focusing on previous epilepsy events that you have had. And is there a connection of this focus to similar to what we discuss when we discuss meditation? The likely origin of this is the anterior insula. So just a quick review here, you see the frontal and temporal operculum pulled back to reveal the insula and the anterior cortex of it. There are case reports where stereo EEG electrodes that are stimulating the anterior insula cause similar effects to ecstatic seizures. There's rapid connectivity and spread to the basolateral amygdala, which again happens to be one of the circuits in the limbic lobe that we almost always investigate in our stereo EEG patients. And here's a quick map. And if you focus on the red in the lower right-hand corner, you can see how densely connected the anterior insula is from the emotional, social, and cognitive perspective to the amygdala and to the hypothalamus and to the cortex. Most likely, these are not reported more often because it is such a small area of the anterior insula. And if the epilepsy starts just next to it or in the temporal lobe or quickly connects to the amygdala temporal lobe, then the semiology, the perceived effect of the seizures, really does overtake this initial origin, and the patient is unable to separate those two experiences to report them. So this interesting paper from 2013 talks about resting state functional and structural connectivity within the insula and amygdala, and then connection to the ventromedial prefrontal cortex, which would potentially allow us to manage our anxiety. So all three of those mentioned are nodes in the anxiety-related processes. They are known to be hyperactive in anxiety disorders, and the possible modulation of this circuit seems to increase gamma power and the ventromedial prefrontal cortex. Is there a component of meditation that potentially builds up resilience and lack of fear as meditators go through this? Is there a way to potentially manage this incredibly complex circuit? And again, to show you guys here, so BLA is the basolateral amygdala and anterior insula is up above. You can see that there's a feedback mechanism with anxiety between those two, as well as other loops that include associative cortices and posterior insula, as well as the hypothalamus. For those of you who are stressed from this, this diagram here, we will go ahead and modulate your anxiety circuit by introduction of happy stimulus, hopefully getting you back away from the anxiety. So what would be beneficial about dampening the amygdala response? Well, regarding potential downsides, this would probably make the Socratic method of neurosurgical education less active. I know George is never going to forget that that's the third cranial nerve. And the reason why is because his amygdala was triggered during the questioning by our chair. And he will forever remember that that's what the third cranial nerve looks like on an MRI. If we are to dampen that, one of the downsides is the Socratic method of emotional education does not work as well. Same thing about the potential triggers that we have for emotional memories in our life. There's a reason why we remember the birth of our child and our wedding day more than we remember just a regular Tuesday. And that includes this limbic circuit emotional memory. But a lot of the times, this amygdala response is not beneficial. And since we have moved away from living in caves and on the plains and running away from tigers, it seems that potentially dampening the amygdala would be good for us. And it would allow us to function better in inherently stressful situations. So can we start considering that part of the limbic lobe, the appendix of the central nervous system? Can this kind of dampening be accomplished through meditation? And can modulation of the circuit done extracranially or intracranially augment meditation and allow us to reach those amygdala dampening states sooner? Well, as an example of a person who's able to achieve this, this is Alex Honnold. And if you have not seen this movie Free Solo yet, I highly recommend it. He is a high functioning person who has minimal activation of his left amygdala, which is proven by fMRIs. What it allows Alex to do is to climb El Capitan in Yosemite without the use of ropes. And he was able to do this in, I believe, just under 4 hours. His ability to function under high pressure situation and continuously focusing on his task is the only way I think that anyone could possibly do something like this. So can we get closer to that state potentially through meditation? Specifically for Alex, most likely genetics have a lot to do with this. His father, although not diagnosed, probably was borderline autistic. And most likely Alex had inherited just enough genetics to allow his amygdala to be dampened in these stressful situations. This can potentially also benefit us in multitasking. And granted, multitasking itself is probably an erroneous term. We never truly multitask. We just switch from one task to another, sometimes efficiently and sometimes not, to give the semblance of an actual process of multitasking. So the ability to switch from one task to the next quickly without getting stuck on a task, rumination, something that obsessive compulsive disorder patients go through, is incredibly important. And I think it's incredibly important in the neurosurgical community. The ability to be able to see a magic trick for what it is the ability to perceive things as they are and not as where the magician is guiding us. And potentially, if we truly are able to switch from task to task quickly, we can most certainly not be distracted by whatever's happening during a magic trick and can see where the card actually goes or when the rabbit gets placed into a hat. Another important component here is the ability to detach from an emotionally loaded situation when it is not useful in your next task. When something unfortunate, horrific happens to a patient and you're done with that patient conversation and you have to move on in your clinic or in your operative day or in your daily life, the ability to detach from what just happened, as long as it is in no way beneficial to your next task, is critical in the field of neurosurgery. And potentially meditation can help us achieve that. Dr. Bettison described this on one of the previous grand rounds, talking about Dr. Betchen as equanimity, as this calmness in a storm. And we now know that this trait, while most certainly inherited, can be developed and can be strengthened. And the other important component here is appropriate allocation of, unfortunately, incredibly limited brain resources that we all have. We're really only able to pay attention to one thing at a time. And how can we get better at that to allow our daily lives as neurosurgeons and neuroscientists and as physicians to become more efficient? So this paper, again, from Richard Davidson's group from Wisconsin in collaboration with a group from the Netherlands, shows that mental training affects your ability on the attention blink task. In brief, what happens during that task is you are shown certain letters and you're asked to focus on a specific letter and be able to catch it. When you are distracted by another letter that is not the trigger, and then the letter that you're tasked with shows up a few milliseconds afterwards, we tend to miss it. We tend to spend too much of our limited brain resource on that previous letter. Chronic meditators are able to catch that second letter. They are able to switch from task to task quickly and are able to appropriately allocate those limited brain resources. So what is happening currently in the field? Well, right now the research is focusing mostly on extracranial EEG, fMRI, and MEG studies. There's really no studies of stereo EEG and meditation. There's really have been no attempts at intracranial stimulation with the goal of reaching potentially meditative states. And there's really limited behavioral feedback in studies with stereo EEG used for that kind of information gathering and guidance of the patient. The only article that we were able to find is one report of a patient who was undergoing stereo EEG for her epilepsy evaluation in Europe, who was also an occasional meditator, and they asked her to proceed with meditation exercises as open to sort of the standard of it, which would just be letting your mind wander. And what they found in that article is when the two tasks were compared, again, mind wandering and breath-focused mindfulness, they first assessed the depth to which her meditation was able to get, and also the thought density. Thought density is something that allows us to know how well the patient was able to focus. Decreased thought density is meditation, whereas increased thought density would be mind wandering. The interictal epileptiform discharges for this specific patient did increase in meditation compared to mind wandering. So this one patient leans us towards the idea that meditation is an incredibly expensive calorie utilizing way to get high gamma up and potentially gets us closer to what we would call seizures. So this gets us to the summary slides. Well, what are seizures truly? Why have certain disorders like schizophrenia and epilepsy remained in the gene pool when there's perceivingly no benefit to them, especially for the patients that we deal with, whose life is in danger every day? Is there a benefit in this incredibly, taxing state of high gamma, that's hypersynchrony? Are we all on a spectrum from normal to Matthew Ricard and then over to a seizure patient? And can we find the optimum of human function on this spectrum to allow us to do the job that we need to do and do it well with potentially help from meditation? And also, do we need to reevaluate what actually happens to the brain when we give somebody Keppra or Dilantin? How far down on that spectrum are they knocked from normal and from those potentially high functioning states to being always sleeping and being unable to function? So we'll come back to this gamma activity spectrum hypothesis, but one of the possibilities is that normal is in the middle and meditation is somewhere between interictal discharges and epilepsy. Why is it important in our center here? Well, I think anyone who knows me has seen these slides before. The movers and the shakers in the history of humanity have had epilepsy. Joan of Arc, Socrates, Van Gogh, Dostoevsky, St. Paul, Alexander the Great. The list goes on and on. Our history as humanity has been created in part by patients who have had epilepsy. So it is an incredibly important disorder for us to figure out and find out how do we get people better. At the same time, it is fascinating to learn and find out truly what seizures are and how interictal discharges can potentially increase our creativity without going all the way to full-blown epilepsy. So the FBI grant that our team was lucky to receive for this coming year will be regarding interoception and meditation. And we would love to invite anyone who is able and willing to collaborate on this. We are building a team to be able to answer some of these questions. Some of the points here would be capturing high gamma in the parietal occipital area, as is proven by EEG, using stereo EEG in patients who have meditation or a potential version of meditation, which we in the Western society would call prayer. We would go ahead and ask these patients to undergo mindfulness exercises before their stereo EEG implantation, and we can compare this to baseline patients who do not go through these meditation sessions. We can investigate the insula amygdala stereo EEG implantation and ask patients to meditate and see if there's short-term or long-term change in their actual brain activity. And we most certainly would love to answer this question. Can we figure out what is going on with high gamma in meditators and also high gamma, high frequency oscillations and interictal seizure-like activity? Another fascinating concept here would be BMI applications. So as we're advancing in the world of brain-machine interface, we know that the neural noise is a significant downside of everything that we do. Meditators can reduce that, and we can potentially enhance the brain-machine interfaces by allowing patients to meditate prior to implantation, thereby significantly decreasing the signal-to-noise ratio. So future directions here, just to pitch it to the wider neurosurgical community, we can do intraoperative testing of neurosurgeons to see what actually happens in that magical moment in the operating room where you truly feel in the groove and everything in the case is going well and you're focused just on the tumor in front of you. And we can do that with a fairly easy device that is going to be inobtrusive to most work with the microscope. We can go ahead and check what intracranial stimulation via stereo EEG or some of the chronic implanted devices like RNS and Precepts can do to augment meditation. We can evaluate the closed loop implants for meditation biofeedback. Can we tell something to patients nowadays to give them a level of potential meditation that they're reaching if these devices are already there to treat some of their disorders? We have most certainly agreed that exercise causes benefit, is of benefit. Unfortunately, what is neglected, and I think neglected in the surgical community, is this idea that meditation is the exercise for the brain and it can cause significant benefits to ourselves, to our trainees. And what I want to introduce is potential initiation of some of these projects with our residency team. And while initially it is a time sink over progression in meditation, what you're able to accomplish with a short meditation session can be akin to 8 hours of sleep. And that I think is something that we need to focus on since we know time is limited for all of us. So with this, I would like to thank the collaborators on the grant, Helen Mayberg, Jake Young, and Allison Waters, as well as our entire comprehensive epilepsy team. And if there is any time for feedback or questions, we would really appreciate it. Thank you so much for your time.
Thanks, Dr. Panov. It's Alex here.
Really beautiful talk, but go ahead, Alex.
Sorry, Dr. Barson, just want to ask a quick question. I think that from a neurosurgeon standpoint, the natural follow-up question is in terms of modulation and what we can do to modulate some of these circuits. Has there been any research to look into specifically activating the amygdala or potentially dampening the response to achieve a somewhat Alex Honnold-like output, if you will, where we have a dampened amygdala response specifically in patients with OCD or who have rumination issues that they're unable to achieve a high quality of life due to this hyperactivity of the circuit?
So not specifically with meditation. There is amygdala stimulation that may improve memory. And there's amygdala stimulation research out there right now for something like even depression. So most certainly this has been done. But again, guys, help out if you can, if you're interested. I've been unable to find any study that specifically tries to trigger that circuit in augmentation of meditation and this incredible concept of potentially allowing you to function in a much higher plane, less emotional and more logical.
Great, thank you.
Ted, is depression and hyperactivity on that same scale? You know, I've had friends and have colleagues whose kids have been on the various medications. On the one hand, they take ADHD type medications to stimulate their activity and they perform better on those medications. Those medications can provoke suicidality. They can provoke all kinds of problems. And then there are people with anxiety and depression who take antidepressants who say, you know, everything's great, but they can't think very well anymore and they don't do as well on tests. Have there been SEEG studies of people on that spectrum of medication?
So the SEEG studies that are just coming out right now, actually out of your former school, UCSF, with Eddie Chang, are starting to investigate depression aside from any other comorbidity. So, you know, we're really able to do this right now only with patients who have a comorbidity like epilepsy. They are doing this straight for depression. They're implanting a stereo EEG and they're monitoring for about 10 days. And they're evaluating this entire circuit, including the limbic lobe and dorsolateral prefrontal cortex, ventrolateral prefrontal cortex. And they're seeing where in that circuit, as their day-to-day mood changes, they're potentially able to influence. And what they want to do is they do want to implant an RNS device later on in those areas. Dr. Mayberg has a lot of incredible and obviously strong, justifiable opinions regarding why that research potentially is not going to be as fruitful as we would want. Because of course, you know, her team has found some of these circuits already. And Dr. Gopal and her are doing these implantations now and getting patients better. I will have to look specifically for medication-induced evaluations of stereo. I'm not aware of those as of yet, but that's such a great potential avenue to proceed, right? Medication is such a blunt tool
Right.
that affects
And
so
it's all
many
over. You
circuits.
may already have patients who are on those meds.
Exactly.
Whose data you can mine now that you have so many. Yeah. So, another comment, Ted, it's such a good lecture you're giving, and I've heard you give various parts of it. I can see the maturation of your thought. You may be ready for a review, to write a review paper or some sort of descriptive discussion of what you just presented. It's really interesting, and I'm sure that would get a lot of interest.
Thank you for saying that. Yep, we'll definitely do that. I think the more we talk about this, the more the interest is created in the community, and the more we'll be able to collaborate. We reached out to Dr. Davidson in Wisconsin, so we're going to start that collaboration hopefully springtime. So we'll get some good feedback for you guys shortly.
Hey, Ted, Ernest, great talk. To your final comments, I mean, it's great to get this talk as a follow-up to Dr. Betchen's presentation last week on leadership and her mention of amygdala hijacking and the brief discussion of emotional intelligence. How strongly do you feel that in terms of resident wellness and even faculty wellness, that we should actually be consistently meditating? I mean, how strong is the evidence that this will improve our performance as neurosurgeons and improve our well-being?
Sure. Well, if you are willing to draw the line that is not connected right now to say multitasking, what we call multitasking, is important in neurosurgery. If you're willing to draw the line at something like an attentional blink test, where you're able to switch from one problem to another instantaneously without carrying over emotional liability from the previous task, if you're able to say that's important in neurosurgery, then the answer is yes, right? No one has really done that in literature. The only downside I see is, again, the classic method of training for us right now includes a significant amount of an emotional challenge, right? That's what we call pimping. That's how we lock something into a memory of a student and a junior attending. I don't know if we have quite found a better, different way to do this. Most certainly they exist, but they would require a lot more brute force memorization versus, again, just Dr. Bettison asking you a question and you don't know the answer and you will never forget it again in your life. So I think we're moving away from what is known as a Socratic method. We know that that is a significant stress to an individual. But at the same time, we have to be cautious in the field of neurosurgery if we truly do that, because what we're doing when the attendings pimp the residents is you are checking how you would respond to a stressful situation. So whichever way you think about it, meditation is going to help. It just may make pimping less effective if you know that you're dampening your potential emotional outcry to a challenging question.
Interesting. Thank you.
Well, guys, thank you so much. I look forward, please call, email, let us know what you think. Let us know
Dr.
if you're
Panov,
going to be involved. Sorry, go ahead. Someone broke up. Hello?
Sorry, Dr. Panov. I just had a quick question. In terms of your clinical experience with patient compliance, given their cultural background, personally, hold on. Can you hear me?
Yeah, keep going. No, Abhi, your bandwidth is low.
No,
I'm sorry
okay.
to cut you short, but let's go ahead and
so I know a few people personally.
Sorry, Abhi. Let's go ahead and do this via maybe an email to the group, or if you want to type it into the chat.
Well, I hope that your data doesn't show that I can't ask questions anymore. Hopefully, it won't evolve that quickly. One of the interesting questions that does arise is, what is required to learn and to form memories. It's a whole different question than how do you multitask. Formation of memories requires intention. It requires some level of activation. It does not happen passively. And there is some degree of stress associated with that state of mind. So, the meditation might help you transition from one active state to the next. But there is something about learning that requires a high degree of activation. And certainly neurosurgery brings you through some stressful times.
That's such an excellent point. And the coolest part of the literature coming out of EMRI, where they're doing amygdala stimulation to augment memory, is something magical happens. They're able to bypass the stress. So they stimulate the amygdala, but the patient does not feel the stress, but the memory improves. So in a way, there may exist a shortcut where that emotional liability is not there, but the memory is actually imprinted much better just because of a specific and appropriate activation of the amygdala.
Agreed. All right. Well, that was fantastic. We look forward to more, Ted. Thanks very much. Great
Thank you,
write-up.
guys.